Good evening, everyone, or good afternoon, depending on where you're watching this from. I'd like to welcome you to what I believe is the final session of this wonderful conference. And I'm really pleased to be the moderator. My name is Mark Uden, and we have a wonderful hour or so set up here for everyone. And the way this is going to work is we are going to have a speaker first for roughly 20 minutes, and then several oral abstracts for about 10 minutes each. And the whole thing should take us about an hour, leaving us hopefully with roughly 10 or 15 minutes for some discussion and questions. So I'm going to get right into it here and introduce our first speaker. And I'm sorry, I'll just interrupt myself to say, and I'm going to remind you of this throughout, that we are going to do all of the questions at the end after all the speakers are finished. And we would like you to enter your questions in the chat. Please, as they come up, just enter them and we will moderate those questions. So I'm really pleased to introduce Dr. Rebecca Zasch, and she is an assistant professor at Harvard and faculty in the Division of Infectious Diseases at Beth Israel in Boston. She's also a research associate at the Harvard T.H. Chan School of Public Health and the Botswana Harvard AIDS Institute Partnership. She's an adult ID specialist consulting on patients with general infectious diseases, and she's also the director of the ID OBGYN Outpatient Clinic. And we were just talking about this. We like to call this reproductive infectious diseases, or RID. Her research is focused on, in Botswana, where she studies the impact of HIV and antiretroviral medications on pregnancy and lactation. She is a member of the US DHHS Perinatal HIV Guidelines Committee and the Sub-Saharan Congenital Anomalies Network. So please join me in welcoming Rebecca. We're so thrilled to have you here. Thank you so much for speaking to us virtually in Canada, and we're thrilled to hear your talk. Take it away.
All right. Thank you so much for inviting me here, and I'm really excited to present to this group. So I'm going to be doing kind of a quick overview about what is the optimal antiretroviral treatment regimen in pregnancy, kind of an updated overview of the safety, the efficacy, and the main research gaps. So these are my disclosures. So, everyone wants to know what is or what are the best ART regimens for pregnancy. People of reproductive potential represent at least half, if not more, of the global population of people living with HIV. And ART coverage is approaching 70% for women globally. And it's pretty obvious, but HIV disproportionately impacts young, sexually active people. And there's more than 2 million women living with HIV who become pregnant every year. Obviously, taking antiretrovirals in pregnancy is critical. It improves maternal health, it prevents a pediatric HIV infection, it decreases transmission to partners without HIV. And ART pregnancy safety data is really critical to HIV treatment programs everywhere in the world to maintain gender equity in HIV treatment outcomes. And yet, we don't have much data for pregnancy. One of the problems is that there aren't very many women who are in trials of antiretroviral treatments. You can see this list here, but basically, women make up less than about a quarter of these really main big ART trials of different medications. There are, of course, notable exceptions, including the Impact Network and several other studies. But we can't really even get women into trials. And it's even worse for pregnant people. So here what you're seeing is that the median delay between FDA approval of an antiretroviral for adults and any pregnancy data, I'm talking PK data, is on average about 6 years. So here's the drug approval, And this is when we got our first pregnancy, just basic data. So the average is 6, and even with the newer drugs like elvitegravir, raltegravir, dolutegravir, darunavir, we're not doing any better recently. There's obvious challenges to studying antiretrovirals in pregnancy. The first I mentioned was the lack of inclusion in pregnant people in trials. And this kind of leads us to post-marketing pharmacovigilance systems that are, generally speaking, fairly inefficient, subject to reporting bias. More people report bad outcomes than report good outcomes, and require healthcare workers to do extra paperwork, which is never good for getting lots of data. Another really hard part about studying ART safety in pregnancy is that it's hard to isolate the effect of an individual antiretroviral medication, because ARVs are pretty much always used in combinations of 3, and they're used in multiple different combinations and often for different indications. And this chart over here just shows you that all the different medications that were used in the UK in pregnant patients between 2005 and 2016. So getting data on specific ARVs and sorting out, is it the drug, is it the combination, or was it the reason that the person got it, is very challenging. And then another major challenge is that it's really difficult, if not impossible, to measure all possible adverse effects of medication exposures in pregnancy. And, you know, if you really think about it, we often focus on things like birth defects or vertical HIV transmission, but there's so many different maternal and pediatric outcomes to think about with medication exposures, from, you know, pregnancy complications like weight gain, other adverse birth outcomes, stillbirth, neonatal death, and then all sorts of longer term pediatric, even adolescent outcomes in neurodevelopment, malignancy, and immune dysfunction. And it's really impossible to have the full picture of safety, not just for pregnancy, but for the entirety of the childhood. So since I don't have a whole lot of time, I thought I would really focus and not go over everything we know, but focus in on what we know most recently with the best data. And it's kind of my opinion, but I think that current data suggests that TAF with FTC and dolutegravir may be the best regimen started during pregnancy. And this mostly comes from the fairly recent publication from the Impact 2010 trial, also called VESTED. And in this study, which was a 3-arm randomized open label study with pregnant women with HIV who initiated one of 3 regimens: dolutegravir with TDF FTC, dolutegravir with TAF FTC, or efavirenz with TDF FTC. And they initiated at 14 to 28 weeks of gestation. And this study looked at both efficacy and safety as their primary outcomes. And what they found was that there was basically similar proportion of women who were suppressed 50 weeks postpartum in all the dolutegravir and efavirenz arms, but that virologic failure was significantly higher with the efavirenz, 10.4%, than the dolutegravir, and it was lowest with TAF FTC DTG at only 4.1%. And then, interestingly, I think kind of unexpectedly, they found that TAF with dolutegravir was associated with fewer adverse pregnancy outcomes. Here you can see 24% compared to 32% for the other TDF-based regimens. And it was really mostly in terms of lower rates of preterm delivery and small for gestational age. And then beyond looking at these main outcomes, they've given us a lot of other data from Impact that I just want to go over. They looked at viral resistance through 50 weeks postpartum in all the treatment arms. And I think the take home here is that in a lot of the virologic failures, there was pre-existing HIV drug resistance, baseline resistance, both in efavirenz and dolutegravir. But there was new HIV drug resistance more often with efavirenz than with the dolutegravir based regimens. And among those on dolutegravir, only one in the TDF arm had an integrase inhibitor mutation, and one in the TAF arm had an NRTI mutation. They also looked at infant growth through 50 weeks. So we saw these interesting sort of lower birth weight and preterm infants at birth, but they were interested to know, does this continue? And basically what they found in the length for age Z-scores, the purple line here is the efavirenz arm, and there was lower length for age and higher rates of stunting in the efavirenz versus dolutegravir arms, though it was pretty similar between the TAF with dolutegravir and the TDF with dolutegravir. They found very similar results for weight for age Z-scores, which was, again, worse in the purple bars, which is the efavirenz, but similar in the other two regimens, and no real difference in the weight for length scores. They also looked at bone mineral density in postpartum women and their infants, and they did a DEXA at week 50 postpartum in 154 participants and 165 infants around 26 weeks. In the postpartum women, they didn't find any difference in bone mineral density Z-scores between the efavirenz and the dolutegravir arms, though it was slightly lower in efavirenz overall. And in the infants, there wasn't any significant difference in the treatment arms for the whole body. But in the spine, the efavirenz arm was lower than the other two. And I think the interesting thing here is that we were expecting there might be differences between TAF and TDF, with TDF being associated with bone mineral density changes. But it actually seems to be TDF combined with efavirenz where it had the effect, and not TDF combined with dolutegravir. And then I wanted to include this because I thought it was really interesting. And they also presented this at CROI this year. So they had a statistician do an evaluation of different ways of looking at multiple outcomes at once in a meaningful way. Because it's hard, there's so many different outcomes in the study, and how do you take that information and sort of make it meaningful? So what they did is, and these are the infant outcomes, but they looked at all the individual outcomes: infant death, spontaneous abortion, stillbirth, down to infant hospitalization. And they did a comparison of each, a two-way comparison for all of the drugs. And here, this side favors the TAF DTG, this side favors the TDF DTG, and this is the TDF DTG versus the efavirenz DTG, and the TAF DTG versus the efavirenz TTG. So they did this for each individual, and then they just combined all of the outcomes into one, doing a standard odds ratio here. So, you know, this clearly favors slightly the TAF DTG, but the differences are fairly small. But they did in the bottom one was that they weighted these outcomes by severity. So, I mean, I think pretty clearly having an infant death or stillbirth is worse than having, you know, infant hospitalization or maybe a grade 3 anemia. So they weighted them. And in this weighted score, you can see that the TAF with DTG was really favored quite heavily in all three of the comparisons. And it's not that, you know, we have to take that at face value exactly, but I do think it's really interesting, and it's a nice way to look at a lot of data put together. So, you know, there's Impact 2010, they had these nice results, but what about the other safety concerns with TAF and dolutegravir, specifically neural tube defects and excess weight gain and metabolic effects? So I'm sure everyone is aware, but in May 2018, the SAPAMO study in Botswana that I work on reported the first possible safety signal for neural tube defects with exposure to dolutegravir at conception. This was at AIDS 2018, and at that time, there were 4 of 426 infants exposed to DTG at conception that were born with a neural tube defect. And then as data accrued in SAPAMO, updates have been really increasingly reassuring with larger numbers. In 2019, the prevalence was 0.3% in about 1,700 exposures. In 2020, the prevalence was 0.19% in about 3,600 exposures. And in 2021, which is the last time we presented, the prevalence was down to 0.15% in close to 5,900 DTG conception exposures. And just to look at that graphically, from March 2019, the prevalence has gone down and the 95% confidence intervals have gotten lower. And the last time we looked at the data, which is in September, it's unpublished, there were a total of 10 in about 7,400 exposures, a prevalence of 0.13%. And this is compared to really large numbers of comparator groups. So people on other non-dolutegravir ART conception, where the prevalence was 0.10% in about 23,000. And you can see because the numbers in this group are so large, the prevalence estimate hasn't really changed at all over the last few years. Similarly, with those specifically on efavirenz at conception, the prevalence has really stayed around 0.07%. And among more than 150,000 women without HIV, the prevalence also is 0.07% with a very small confidence interval. And so kind of taken together, when we're looking at the prevalence difference between those on dolutegravir at conception and the other comparison groups, the prevalence difference is extraordinarily small, from 0.04%. So that's 0.0004. And 0.07% for the others. So, I think what's come of this is that these differences are extraordinarily small, and the data really support guidelines for the use of dolutegravir as first line among pregnant people, people of reproductive potential, and people trying to conceive. But then there's also this issue of weight gain. And I think there's a lot of recent evidence suggesting that TAF and integrase inhibitors, in particular dolutegravir, are associated with excess weight gain in non-pregnant adults. And the risk factors seem to include female gender and being Black and African. And some of the best data is from the ADVANCE trial in South Africa, which was a 3-arm randomized controlled trial of ART treatments in non-pregnant adults living with HIV in South Africa. And here you can see the proportion of people who had treatment emergent obesity. This is a proportion of women from baseline up until 96 weeks. So among people randomized to TAF with FTC and dolutegravir, 14% had treatment emergent obesity, compared to 8% who were randomized to tenofovir, TDF, with dolutegravir, and 2% who were on TDF, FTC, efavirenz. And the reason this is important for pregnancy is because both maternal obesity and excess gestational weight gain have the potential to really worsen pregnancy outcomes. So what we know so far is that weight gain in pregnancy does seem to be higher with dolutegravir than efavirenz. There's observational data from our SAPAMO study where pregnant women were on TDF FTC with dolutegravir or efavirenz, as well as a group of women without HIV. And in this study, we found that weight gain per week was higher in the dolutegravir than efavirenz, especially for people who weighed over 80 kilograms at baseline. Though interestingly, I think it's always important to look at this, is that people without HIV actually had higher weight gain than either the dolutegravir or the efavirenz group, really across the board. And then in the VESTED study, where they were able to compare the TAF to the TDF with dolutegravir and the efavirenz, found really similar results. So the highest weekly weight gain was with TAF FTC dolutegravir. This was higher than with TDF FTC dolutegravir and higher than TDF FTC efavirenz. And then, the other thing that we did, which I think was important, was to look at the other end of the spectrum as well. So this is a table showing weight loss and insufficient weight gain with efavirenz and dolutegravir from the SAPAMO study in Botswana. And, insufficient weight gain and weight loss also have adverse effects on pregnancy. And what we found was that more people on efavirenz-based ART, 27%, had insufficient weight gain compared to 20% on DTG-based ART. Similar results for weight loss, 9.4% versus 4.4%. And again, overall, even the DTG group had much more insufficient weight gain than women without HIV, 20 to 11 and 4 to 2.2. And so weight gain may be a little bit more complicated and maybe of benefit to some pregnant patients living with HIV, but certainly not everybody. So in the Vested 2010 study and in SAPAMO, people on DTG, as I said, didn't gain as much weight as pregnant people without HIV on average and gained less than the IOM recommendations overall. And in SAPAMO, women with lower weight had higher risk here, lower weight, of severe birth outcomes, which included very preterm delivery, very small for gestational age, and perinatal death. Having said that, they also had lower risk of maternal hypertension by quite a bit. So, I think this is just stating that the issues with TAF and weight gain and dolutegravir are not totally straightforward and probably depend a bit on who the patient is, whether they're starting ART during pregnancy, whether they've been on for some time, what their baseline weight is. And it's not just, dolutegravir and TAF are going to cause pregnancy adverse outcomes because of the weight gain. And then we don't have a lot of data on other metabolic outcomes with TAF, FTC, dolutegravir. The Vested study did evaluate hemoglobin A1C and random glucose in the trial while the patients were pregnant, so at 12 weeks and at delivery, and also in 65 of the infants. And basically what they found, and you can see here, is that there was a slight trend for hemoglobin A1C to be slightly higher with the TAF, FTC, dolutegravir group, but there was really no statistical difference. And similarly, the proportion of people who were pre-diabetic, meaning they had a hemoglobin A1C over 5.7, was slightly higher in the TAF with DTG, but not significant. So we don't have a whole lot of data on metabolic outcomes with this regimen. So, this is kind of the best data that we have right now. I think there's a lot of research gaps, and I have certainly not listed them all here. But to me, one issue is that the most robust data that we have for pregnancy are for TAF, FTC, dolutegravir, TDF, FTC, dolutegravir, and TDF, FTC, efavirenz. And no similar data for outcomes really exists for other common regimens that we would want to use in pregnancy, including the modern protease inhibitors like atazanavir and darunavir, the newer integrase inhibitors like bictegravir and elvitegravir, and certainly not the long-acting injectables like cabotegravir and rilpivirine. And it's really urgent that we get similar comparative efficacy trials if we really want to know what the safety profiles of these are compared to what we know about the TAF dolutegravir regimen. We also have the most robust data for TAF, FTC, dolutegravir among people who start their regimens during pregnancy. And, in all of the settings I practice, that is becoming more and more rare, and most people have started prior to conception. We don't have conception data specifically for TAF. We really hope that there's not any issues because TDF appears quite safe at conception, but that data just doesn't exist yet. And then I think we need more information and research on the impact of weight gain, and metabolic complications for people not who start during pregnancy, but who have been taking these regimens associated with increased weight for years, and what happens during their subsequent pregnancies. It may take time to gain the excess weight that could potentially be harmful to a pregnancy. And we also have, very little data on the long-term pediatric outcomes with most of these modern antiretrovirals. I think there's some great talks today, and I know people are working on this, but it's something that's been very hard to get data on. And then lastly, I think, we really need to understand why there are so many more adverse birth outcomes among people living with HIV, and what the mechanisms there are. Is it related to the HIV, specifically to the ART, or just to sort of socio-demographics and concomitant racism, class inequality, and things like that. But I think really figuring out what's causing this also helps us mitigate any effects of ART in the future. So my very last slide, I just want to say that I'm trying to be more positive this year than I've been in the last few years about everything. And I actually do think that even in my pretty short career, there has been a shift in how people are thinking about getting pregnancy safety data. I wanted to point out this really amazing study called Pregnancy and HIV Seeking Equitable Phases, and they published their results, I think in 2020 or 2021, and really looking at how to have an ethical framework among for getting pregnant patients and pregnancy safety data with specific recommendations. And I think it's just a very kind of, sometimes this we're never going to get pregnancy data feels futile, but this study really makes it feel like we can make a lot of progress. And then I just wanted to point out that just generally speaking, getting pregnancy safety data was big news during COVID and around vaccines, and all these major networks, Bloomberg, NPR, Time, Washington Post, had this in the news for a while. So I think it is becoming more widely recognized as one of the things that we really need to improve. So thank you so much for listening, and I will stop there.
Wonderful. Thank you so much. That was a great talk and a great overview of the medications. So I just want to remind everybody, if you have comments, questions, things you'd like to discuss, please enter your questions and comments in the chat, and we will go to the chat at the end. We are going to now hear from our oral abstract presenters. And the first presentation is from Jean Brochant, and the title of her talk is Neonatal Combination Antiretroviral Prophylaxis for the Prevention of Vertical Transmission, a Risk-Based Assessment.
Yeah, thank you, Mark. I hope you can all see my screen and hear me. I would like to thank CAHR to let me present this work, which is a risk-based assessment on postnatal prophylaxis for the prevention of vertical transmission of HIV. I'd like to acknowledge that my work takes place in Turkey, from where I speak on the unceded lands of the Mohawk Nation. So first, little epidemiology. So in Canada in 2019, there were 62,000 people living with HIV. We know that vertical transmission has decreased from 20.2% in the 90s to 1.3% in 2015 and 2019. And we saw from previous presentation that there were an increasing during COVID pandemic as for vertical transmission too, and it was 3.2%. We know that there is a high burden of RT, which side effects that are well known, and combination of RT can lead to premature discontinuation and increased risk of side effects. And there are some work about long-term effects on children HIV exposed who are uninfected, with increasing morbidity, risk of infectious disease, hospitalization, stenting, and poor growth, and poor neurodevelopmental outcomes. And we can ask ourselves, what is the role of RT? In Canada, the actual recommendations are to prescribe zidovudine for 4 weeks to the children when the maternal viral load was undetectable, and that you received the combination of RT for more than 4 weeks during pregnancy with an optimal adherence. And an enhanced postnatal prophylaxis, EPNP, for 6 weeks is prescribed to the children with zidovudine, lamivudine, nevirapine, or raltegravir when viral load was more than 1,000 and there is no or less than 4 weeks of therapy during pregnancy with a poor adherence. But what about the viral loads between 20 and 1,000? One of the most conservative approaches would be to give EPNP to every children. However, there is a risk of adverse events. It needs investment, careful monitoring, follow-up, and difficult access in remote area and side effects. And there are different international guidelines about it with different cutoffs of viral load, which would be 50 in the UK, 400 in France, or 1,000 with WHO. So our objectives were to describe EPNP use among newborns of people living with HIV in Canada and determine risk factors for its utilization, and to determine risk of vertical transmission across different risk categories, specifically with low-level detectable maternal viral load. We conducted a multicentric retrospective cohort study from 1997 to 2021 with the Canadian Perinatal HIV Surveillance Program initiated in 1991 from CAHR and the Public Health Agency of Canada. There were 23 centers, and mother infant pairs were included by each center, and demographic, clinical, and HIV-related data were collected annually and retrospectively by each of the centers. We included all children born to people living with HIV in one of the participating centers, and excluded those born outside of Canada or those who were diagnosed HIV after birth. So in total, there were 4,900 mother infant pairs in the database, and we included 4,700 dyads of them, for which 1,852 data were missing for our risk definition. So we categorized 2,891 dyads into 3 risk categories that were high risk with viral load near delivery more than 1,000, or a maternal treatment less than 4 weeks prior to delivery, a medium risk with viral load near delivery that was detectable but less than 1,000, and maternal treatment during pregnancy more than 4 weeks, and then a low risk with undetectable viral load and a treatment that lasted more than 4 weeks. So we got 70% of the children on single RST, 14% on dual RST, and 30% on CRT. We can see that when women were diagnosed during pregnancy, half of the children received a single RST, 20% a dual RST, and 25% a combination of RST. When there was no treatment during pregnancy, 45.4% of the children received no PNP or monotherapy. And where there was a treatment for less than 4 weeks, only 43.8% of the children received the combination of RT. Regarding suboptimal adherence, when children received only 35.5% of CRT. And we got a lot of missing data for viral load, almost 6%. But for these who got undetectable, there was still 24% of children on dual or CRT. And for those who were detectable with but less than 1,000, it was quite heterogeneous. You can see here that Ontario was one of the most, the biggest center to take care of the dyads, and then it was Quebec. And here is the postnatal prophylaxis according to site. In orange, this is the single therapy, in gray, dual therapy, and in yellow, CRT. You can see that every states are between 70 to 80% for single therapy, except for Quebec, who prescribed 23% only of single therapy, and much more dual and CRT. Those are the drug regimen according to risk categories. So in total, we got 28.8% of the children in high risk category, 6.8% in the medium risk, and 65.1% in the low risk. What we can see is it's the same color legend with orange in single, gray in dual, and yellow in CRT. And in the high risk group, there was 46.8% on monotherapy and only 25.5% on CRT. Whereas in the low risk group, there are 76% on single therapy, 16% on dual, and 5.8% on CRT. Here are the risk factors for the CRT. So we got maternal viral load being detectable, being diagnosed during pregnancy, not receiving any treatment or less than 4 weeks treatment, and having a suboptimal adherence. Those are the risk factors for HIV transmission in our study, and without any surprises, we got not having any treatment or being treated less than 4 weeks, having a detectable maternal viral load, people living with HIV that were injected drugs, being diagnosed during pregnancy and having suboptimal adherence and non-adherence, which is related to not being into treatment. Those are our transmission according to risk category, and in total, 39 children were in the high risk group, 1 in the medium risk, and 5 in the low risk group. The only one in the medium risk was from the suboptimal adherence group, and the 6 that were living with HIV were in the medium and low risk group, received a CRT, and we can ask ourselves if it was not a transmission in utero. And for that, we wanted to see in this group if there was less transmission of HIV because of CRT, but it seems that it was not significantly different. So overall, EPNT was not sufficiently prescribed for children born from people living with HIV who were not on treatment or for less than 4 weeks of therapy during pregnancy. Children born from people living with HIV whose adherence to treatment was suboptimal. And we saw that in high-risk group, only 25.7% of the children were on CRT. There was no benefit to EPNT in low and medium risk situations in reducing transmission. However, it was used quite frequently, and CRT was prescribed in 26% for medium risk and 5% for low risk groups. We had a few limitations. First, as we saw, a center bias. There were lots of changing of recommendations over time. We had many missing data and uncounted variables in physicians' decision-making. To conclude, monotherapy is safe in low-risk groups, and suboptimal adherence seems to be an important risk factor for HIV transmission. In the medium risk group, there was no transmission when adherence was excellent, and there was no use of EPNT. And the only one transmission occurs with suboptimal adherence despite EPNT. So maybe monotherapy should be considered for this medium risk group as long as adherence is excellent. And here is the reminder of the WHO guidelines from 2021, where there is just a low risk and high risk group with a cutoff of viral load at 1,000. So we need to optimize use of EPNT, especially where it's most needed and where there are problems of accessibility to drugs and ART, and to better identify high-risk situations. I'd like to thank you for your attention and all the people that helped me with this work.
Thank you so much. We will keep moving. And once again, I will remind you to enter your questions in the chat if you have them. So next talk is by Kara Sang, and the title of her abstract presentation is Developing Consensus Guidelines on Infant Feeding for Women Living with HIV, a topic that a lot of us know and love, and that certainly is controversial. So we're very excited to hear your talk. Go ahead.
Thank you so much, Mark. Hi, everyone. I am presenting on behalf of our co-authors listed today and the Canadian Pediatric and Perinatal HIV/AIDS Research Group. Developing consensus guidelines on infant feeding for women living with HIV in Canada has been an effort that started many years ago, and so we are really excited to share our results with you today. To understand why we developed these consensus guidelines, we have to first understand the historical context. So HIV was first cultured from breast milk in the 1980s, and soon after, in 1985, the first cases of breast milk transmission of HIV started to be reported. 25 years after that, The BAN trial was the first trial to compare infant and maternal interventions to reduce HIV transmission risk. And the HIV transmission risk of each of the following trials that I'll be discussing is in the brackets. 2 years later, the HPTN 046 trial investigated infant nevirapine prophylaxis to reduce transmission risk. And 6 years after that, there was the Impact Promise trial, also the most recent trial, which compared infant and maternal interventions to reduce HIV transmission. So it's important to note that all of these trials took place in low resource settings. And overall, the point is to show that all of these interventions can significantly reduce, but not eliminate the risk of vertical HIV transmission through breast milk. And so in low resource settings, exclusive formula feeding is recommended due to increased survival. 2 years ago in 2020, the Well Project published their expert consensus statement on breastfeeding and HIV in the US and Canada, and they recommended exclusive formula feeding in resource-rich settings. In parallel, our group had also raised it as a priority to review the available evidence to provide guidance and in the prevention of vertical HIV transmission, specifically in the Canadian context. And so we developed this guideline under 3 main guiding purposes. So firstly, we wanted to make sure that all of the guidance and strategies that are made are based on the review of the best and most current available evidence. Second, we want to provide guidance specifically for counseling women and their support persons so that they can make the best informed decision. Third, as clinical management strategies are difficult to find and sometimes missing, we wanted to delineate these strategies for providers when caring for women living with HIV who decide whether to formula feed or breastfeed their infants. Again, we wanted to develop these guidelines through comprehensive literature review and through identifying the needs from women living with HIV and their providers in Canada. So to develop these guidelines, we wanted a multidisciplinary committee to provide feedback on our many iterative drafts. And so these individuals include Canadian medical experts, Canadian HIV researchers, community advisors with relevant knowledge, expertise, and experience in the area of HIV and infant feeding, AIDS services organizations, as well as a legal consultation. So our guideline is framed around 7 main recommendations with supplementary material and appendices. So I'll just go through each of the 7 recommendations, followed by explaining what the supplementary and appendices include. So the first recommendation is that we recommend exclusive formula feeding for infants born to women living with HIV in Canada. We emphasize the importance of culturally inclusive supports to help women cope with any impacts that they may experience with not breastfeeding. Following comprehensive, unbiased counseling, providers must understand the beliefs and goals that women have concerning their infant feeding choices to adequately counsel them. And so the second recommendation revolves around infant formula accessibility. So currently in Canada, infant formula is available in most areas of the country at no cost, which eliminates the possibility of breast milk transmission of HIV. However, of course, accessibility is contingent on many factors such as geography, transportation barriers, access to clean water, disclosure imperatives, and pharmacy knowledge and support. So we advocate that free formula should be made available for all infants to mothers living with HIV for the first year of their life. The third recommendation is that all women living with HIV should benefit from multidisciplinary counseling about infant feeding well in advance of delivery by adult HIV, pediatric HIV, and prenatal care providers. Care providers should engage all families in a dialogue to answer any questions about infant feeding options, understand motivations for choosing a specific feeding method, all the while doing so in a non-judgmental manner. The consultations should include different types of infant feeding, the current global guidelines, and the science of HIV transmission through breast milk, including unknown long-term outcomes of ongoing infant exposure to maternal antiretrovirals, as well as interventions and advice relevant to when formula feeding or breastfeeding. The fourth recommendation is that as a prerequisite to breastfeeding, healthcare providers should counsel and support women on how to optimize their health and minimize the risk of HIV transmission through breast milk. So some of these counseling topics could include adherence with combination antiretroviral therapy and sustained virological suppression, regular attendance to prenatal care and follow-up visits, awareness of potential risk of HIV transmission with breastfeeding. And so the fifth recommendation relates to the mother. So for women who meet the criteria to breastfeed, monthly maternal monitoring, including viral load testing and follow-up, is recommended until cessation of breastfeeding to ensure ongoing support. And summarized in the bullet points are maternal clinical recommendations for women while breastfeeding, which includes maintaining adherence, virologic suppression, and optimal breast health, minimizing total duration of breastfeeding, and recommendations about weaning. And then in the table, we also have common contraindications for breastfeeding that a provider should look for. And the sixth recommendation then relates to the infants being breastfed and developing a comprehensive management strategy for them. And so a comprehensive management strategy would include antiretroviral prophylaxis, HIV PCR testing, neurodevelopmental follow-up given the unknown additional effects of prolonged antiretroviral prophylaxis through breast milk, as well as monitoring the infant's oral and gut health. And so again, in this table, there are common contraindications to breastfeeding to look for in the infant. And so our last recommendation is that service providers should not report a person living with HIV to Child Protection Services or the police for breastfeeding. We also conducted a legal consultation on the laws, rights, and HIV in the context of infant feeding, which has been formalized into a report that has been attached to the guidelines. And so now that we have gone through the 7 recommendations, I'd like to talk a bit about the supplementary material and the appendix. So we wanted the recommendations to be a very concise document that people can easily refer to. And so we have supplemented the guidelines with supplementary material as well as an appendix. And so the supplementary material is essentially the literature review on which our guidelines are built. They provide references in a lot more detail about the current guidelines, the science behind vertical HIV transmission, and a lot of relevant topics surrounding this, as well as any current unknowns in this field. The appendix then includes easy to access resources for providers, such as dosing guidelines of infants, as well as additional background information about HIV transmission. There is also an agreement template for breastfeeding when a mother is living with HIV. And then lastly, the legal consultation report that I previously mentioned. And so in conclusion, our guidelines are designed to inform and enable better care for women living with HIV and their infants. We recommend that formula feeding is the preferred method of infant feeding as it eliminates the risk of transmission. We highlight that comprehensive maternal and infant management strategies are required to continuously evaluate the appropriateness of breastfeeding. Of course, with new evidence, we expect to continuously evaluate and change these guidelines. Community members emphasize the need for support and counseling for effective formula feeding and access to formula. And the legal consultation clarified the language around child protection services, as well as the need to provide referral to legal resources. And so what we're planning to do next is to develop knowledge translation resources to accompany these guidelines so that this content is accessible and able to facilitate these conversations with between care providers and the community. And so with that, the co-authors would like to thank our funding partners, our collaborators and advisors who contributed resources, their expertise, and also dedicated abundance of time to develop these guidelines. So thank you for listening, and I welcome questions during the panel discussion.
Thank you so much. We will keep moving along. So the next speaker is Marisa Lee Smith. and she will be speaking to us on her topic, second generation integrase inhibitors, induce toxicity and differentiation in human embryonic stem cell models.
Perfect, thank you. I would just like to thank the organizers for including me in this special session, and also my supervisor, Dr. Lynn Cote. Each year, approximately 1.1 million infants are exposed to ARVs in utero. Although these drugs are very good at suppressing viremia and preventing transmission from mother to child, there is a gap in knowledge regarding the safety of many ARVs in the context of pregnancy. There are more than 30 different HIV drugs that could be used in combination to treat HIV. Thus, it's imperative to identify drugs that are, quote, pregnancy safe. The majority of the newer and most popular ARVs are INSTIs. First, we have RAL that must be taken twice a day, and there's no fixed dose pill, but it appears safe for use during pregnancy. EVG is available as a fixed dose pill taken once a day, but there is reduced placental transfer of the drug, and thus it's not really recommended for use during pregnancy and was not investigated in my study. These first two approved drugs are classified as the first generation INSTIs, with the next three known as second generation. DTG is also a once per day pill, and its safety during pregnancy has been slightly controversial as there has been mixed data collected. BIC is a newer drug with, again, only one pill a day with limited pregnancy data. And lastly, we have CAB, which was very recently approved and can be administered as an injection once a month or once every 2 months, which is very revolutionary for the field, but there is no thorough pregnancy data with exposure to the injectable CAB. So understanding the safety of ARVs in these early stages of embryonic development is crucial. For example, the safety signal of the increased neural tube defects with exposure to DTG discussed by Dr. Zash earlier, although small, could be a canary in the coal mine, indicating a host of other issues that may arise later in life. Let's first dive into what is actually happening during early embryonic development. So once fertilized, the zygote divides, and within that first week, the embryo begins to form structured layers and becomes a blastocyst. So this would continue maturing, and within only 4 weeks, become an early stage fetus with a fully formed neural tube. Thus, any defects that would have occurred prior. Within that blastocyst, though, is the inner cell mass, and that's where we derive human embryonic stem cells that are used for research. These cells are self-renewing and pluripotent. Pluripotent meaning that they give rise to many different cell types and tissues in the body. These pluripotent cells can be targeted to differentiate into the 3 germ layers, namely the ectoderm, mesoderm, and endoderm, and can continue to differentiate into more defined cell types and tissues, where ectodermal cells will form the nervous system and skin, mesodermal cells form muscles and connective tissue, and your endodermal cells will turn into things like the digestive system and other internal organs. Now, the signaling and the timing of these processes are crucial to ensure proper development and, for example, the eventual successful closure of the neural tube and other fetal formation. So bringing these two together, my objective of the study was to characterize and compare the effects of INSTIs on cultured human embryonic stem cells with respect to markers of cellular health and pluripotency. In my study, I utilized 2 distinct embryonic cell lines, namely CA1S or H9. These cells were cultured and passaged into wells containing drug at concentrations ranging from 0.001x to 3x Cmax, in which 1 Cmax is considered the peak plasma concentration of drug found in a person's blood. I then conducted 3 independent replicates on the CA1S cells and 6 on the H9, cultured them for 3 days, and assessed them via flow cytometry. So for the flow cytometry, I looked at a few different markers. The first were cellular markers, checking out the viability of the cells, are they still alive, as well as apoptosis, seeing if they were undergoing programmed cell death. I also looked at pluripotency markers. We need to make sure that the embryonic stem cells are remaining as embryonic stem cells. So the first marker is SSEA3. That would be lost pretty early on once the cell decides to differentiate, and TRA160, which would be lost a little bit later. So the x-axis on the following graphs will indicate drug concentration increasing from left to right, and the color of the lines denote the specific INSTI exposure. That black horizontal dashed line indicates the effects of the DMSO control, in which all the drug treatments have been normalized to. So with this first graph, we have live cell count, and we do see a reduction with exposure to BIC, CAB, and DTG, starting at the 0.1x Cmax drug concentration. When we look at viability and apoptosis of the cells, we see starting at the 1x Cmax, a decrease in viability and increase of apoptosis with exposure to BIC. And in terms of the pluripotency, we see a loss of that early marker, the SSEA3, starting at a very low concentration of both BIC and CAB. DTG and CAB. Overall, we're not seeing anything with raltegravir. We confirm these results in a second cell line, the H9 cells, with a reduced dose response. So instead of the 10 different doses, we were looking at 4. Again, with the live cell counts, we're seeing at the 0.5x Cmax a decrease in cell count with the CAB and DTG. In terms of the viability and apoptosis, we see with exposure to BIC and DTG at the 1x Cmax a decrease in viability, as well as an increase in apoptosis. And for the pluripotency markers, we see that both of them are affected with exposure to CAB and DTG, starting at around the 0.1 to 0.5x Cmax concentrations. So to summarize all of that data, we can fill in this table together. So first, with the bictegravir, even at subtherapeutic concentrations, we're seeing a decrease in cell count. We also see some decreased viability and increased apoptosis. For the DTG, again, similar cytotoxicity with cell count. With the H9 cells, decreased viability, increased apoptosis. But we're also seeing this loss of pluripotency markers. Cytotoxicity also noted with CAB, and similar to the DTG, a loss of those pluripotency markers. Again, nothing with RAL. It was completely the same as the controls that were used in the study. So there's something going on with the cytotoxicity, but there's definitely something going on with the loss of pluripotency. If these cells are no longer pluripotent stem cells, what are they turning into? So to answer that, in addition to the flow cytometry, I also conducted RT-qPCRs to assess the expression of genes associated with pluripotency, as well as those of the 3 germ layers. So cells were grown as before and treated with just the 0.5x Cmax, and I did 3 independent replicates for each of the cell lines. So on this heat map, each treatment is normalized to the DMSO control, which is set at 0, or it would be a white color if the treatment is same. We have the different genes on the left-hand side, those indicating pluripotency or endoderm, mesoderm, ectoderm expression. With the CI1S, we're a little bit all over the place, and there's not too much expression, whether it be up or down. But when we look at the H9 cells, we do see quite a bit of increased expression with exposure to BIC, CAB, and DTG in terms of endodermal and mesodermal increased expression. So there could be something going on here, and it could be pointing towards maybe specific timings being changed in an early embryo, which is what it could possibly be translated to. So to summarize all that and sort of look at the bigger picture, we're seeing that even at subclinical concentrations, some INSTIs, particularly the newer ones, induce cytotoxicity and differentiation in my embryonic stem cell models. And we're also seeing that trying to put it together, the signaling and the timing during embryonic development is critical. Thus, something happening at these early stages could translate to something negative happening either earlier once the child is born or later on. Overall, a big point that I want to come across is that RAL appears to be a safer alternative that might warrant some further clinical investigation. I just want to say a big thank you to all my COTE lab members. A thank you to the Pure A lab for providing the cells, and the CAHR and the Center for Blood Research for the funding. Thank you so much.
Thank you for that talk. And we will now move to our final abstract. And following this, we will have a short Q&A session. So it's my great pleasure to introduce our final speaker, Lena Sergides. We were joking about how there's multiple different pronunciations of both of her names, first and last. Lena and I have been friends and collaborators for more years than I care to admit. And so I will let Lena have the floor for the last talk, evaluating the association between perinatal HIV, ART exposures, and entry into puberty.
Thanks, Mark. So you can hear me, right? It's all good. All right. So thank you all for staying till the last session. And I just wanted to let you know that we are able to stay a little bit longer if people want to stay for the discussion. Okay, so here today I'm going to talk to you about puberty, and I just wanted to acknowledge my co-authors on this paper. So puberty onset and deviations in puberty onset can actually have an impact on health, and this is why we like to look at them. So early pubertal onset has been associated with shorter stature, poor self-image, depression, increased risk-taking behavior, later obesity, diabetes, and cardiovascular disease, while late pubertal onset has been associated with increased risk for psychosocial pathology, depression, and low bone mineralization. And many factors can influence puberty onset, including genetics, race, nutrition, body fat, stress, environmental exposures, and also childhood infections in inflammatory diseases. So we know a little bit about puberty onset in the context of HIV, where studies have observed delays in pubertal onset in both boys and girls with perinatal HIV compared to the regular, the control population. And also studies have found that low CD4 count and higher viral load were associated with delays in pubertal onset in these kids, and this was more pronounced in boys over girls. Further, longer exposure to antiretrovirals is associated with earlier pubertal onset. However, not much is known about children who are HIV and ARV exposed but remain uninfected, and this is an important population that is growing rapidly as we're getting really good at preventing HIV transmission. Okay, let's see. So the aim of our study was to describe and compare puberty stage at age 9 in children who are HIV exposed uninfected, so HEU, by type of ART exposure and maternal HIV disease severity. So we did this in kids that were participating in the surveillance and monitoring for ART toxicities, the SMART study, which is part of the pediatric HIV/AIDS cohort, so the FACS cohort, which is a large cohort that follows HEU kids in the US. These kids had to have a Tanner stage assessment at age 9, plus or minus 4 months, and we needed to know their type of in utero ARV exposure and their maternal viral load and maternal CD4 count in pregnancy. So of all the kids in SMART, which was 931, there were 227 children that met this criteria, 113 boys and 114 girls. Our inclusion period was between 2017 and the start period varied depending on the site, and April 2022. So our outcomes were Tanner stage 2 or greater at age 9, which is the transition to puberty. So that's considered moving from stage 1 to stage 2 is the onset of puberty. And here I put as a graphic as how we score puberty, this Tanner staging. And it's funny, during this time, my kids were actually transitioning to various stages of puberty. And I think they got suspicious of me looking at them, trying to verify what the graphic looks like in reality. But anyway, so we have male genitalia and female breasts which are signs of gonadarchy, and pubic hair, which is a sign of adrenarchy. So we looked for whether a child was stage 1 or stage 2 or greater at age 9. The exposures we looked at was protease inhibitor exposure at less than 30 weeks of gestation versus no PI exposure either at over 30 weeks or any other kind of ART exposure. And CD4 count, this is maternal CD4 count in pregnancy and maternal viral load in pregnancy. And we took the earliest available of these two measures. We looked at possible confounders, sex, of course, because puberty tends to occur earlier in boys and girls, in girls than boys. So we did analysis stratified by sex. We looked at race and ethnicity because the onset of puberty tends to occur earlier in Black children. This is particularly true for girls. Maternal pre-pregnancy BMI, because high maternal BMI is associated with earlier entry into puberty for both males and females. And socioeconomic status and social history, which we try to, as a surrogate, use household income, because some studies have shown that early life adversity and lower socioeconomic status are associated with earlier pubertal onset. We also looked at child BMI as a mediator because higher BMI is associated with early entry into puberty in some studies. But because we thought BMI could be in the causal pathway, we didn't include it as a confounder. So our analysis is we described Tanner stage at age 9 by each of exposure for boys and girls. And we also fit log binomial regression models to determine prevalence of Tanner stage 2 or greater in this kids by each of the exposures and adjusting for potential confounders. So just overall, we found that indeed, as we expected, the higher proportion of girls had puberty onset, so Tanner stage 2 or greater at age 9. So 34.2% of the girls had a onset stage 2 or greater for breasts, and 31.9% for pubic hair, 27.4% for both. And in boys, we had 16.8% having a Tanner stage 2 or greater for genitalia, 13.3% for pubic hair, and 12.4% for both. Characteristics, this is, I know it's busy and it's not even the complete set, but I'm just going to highlight. So this is by Tanner stage for male genitalia. And what we found is that there was a higher proportion of children with a BMI greater than the 95th percentile in those that had Tanner stage 2 or greater for male genitalia, lower proportion with a PI exposure in utero, and a higher maternal viral load in pregnancy. And this was similar to what we saw when we looked at those with Tanner stage 2 or greater for male pubic hair. Now, in the females, when we're looking at breast, Tanner stage 2 or greater, we had a higher proportion identifying as Black and a higher proportion with a child BMI greater than 95th percentile in those with a Tanner stage 2 or greater. But interestingly, different than what we saw with the males, there was no difference in PI exposure or really in maternal viral load in pregnancy. And again, similar when we looked at the female pubic hair by Tanner stage 2. So when we look at child BMI Z-score, so this is the reference was children with a BMI less than the 95th percentile versus over 95th percentile. And here I'm showing relative risk. The circles are unadjusted, the squares are adjusted. So this is for genitalia, pubic hair, breasts, and pubic hair for girls, and I try to separate it, blue for boys and pink for girls. And here you can see that overall, all of them having a BMI over the 95th percentile seems to be associated with a greater chance of having a Tanner stage 2 or greater for all the attributes, but really it only was significant for the unadjusted male pubic hair and for female breasts. When we looked at PI exposure at less than 30 weeks gestation and Tanner stage, what's interesting here is that the boys and the girls are behaving differently. We see no impact on PI exposure in females having pubertal onset, but we see it in the males with those with a PI exposure having a lower chance of having reached puberty onset at age 9. These were trends, but our numbers were small, obviously, but there was a trend there in the males, but nothing in the females. When we looked at maternal CD4 count, we really didn't see any association with pubertal onset on either males or females. But when we looked at HIV viral load in pregnancy, so this is maternal, and again, the earliest viral load that we had available, again, we see a difference between males and females with a 1 log increase in maternal HIV RNA in pregnancy being associated with approximately a 2-fold more likely to have entered puberty by age 9 for the males, regardless of whether you're looking at genitalia or pubic hair, but no association in females. So to summarize, For boys, we see higher maternal viral load in pregnancy associated with greater chance of having entered puberty by age 9. And again, for boys, we see that in utero exposure to PIs may be associated with a less chance of having entered puberty by age 9. We see no associations in girls. And of course, we do have limitations of small size. The Tanner stage was only assessed at age 9. Most of our participants were exposed to PIs, and we don't have an inclusion of children without HIV exposures, although we are working on this. So I'd like to thank all the FACTS participants, clinical sites, and the FACTS team. This FACTS is supported by the NIH, and I'd like to also acknowledge all the funders to support my lab. Thank you.
Okay, first of all, thank you so much to all of our speakers. And we appreciate everyone's attention and sitting through all of these talks without asking questions. So it is 5 to 7. I have the authority to go a bit later than 7, although I'm sure that many of us don't want to go much later than 7 on a Friday. However, I would like to have a chat discussion for a few minutes. So you can continue to enter questions in the chat, and I will try to choose the ones that have the most comments. So the first is just a comment that several people endorsed good work with the recommendations on infant feeding. Again, I mentioned at the beginning, that's a very challenging topic with a lot of emotion attached to it as well. So it's always a challenging thing to speak about. So really, I echo that. Congratulations. So our first question is for Rebecca, Dr. Zash. Your study has single-handedly contributed immensely to our understanding of the safety of ART in pregnancy. Botswana is a special setting that allowed the SIPAMO study. How do you think we can get the data we need on safety of DRV, BIC, and CAB-RPV without those being introduced in Botswana? And of course, I also wanted to congratulate you on distilling a somewhat challenging group of data for us in a very short time period.
Thanks. I think that's a fantastic question. You know, I didn't include this, but the vast majority, about 90% of pregnant people living with HIV are in sub-Saharan Africa and India. So getting the volume of data that we can get in the short amount of time is going to have to come from those places, generally speaking. However, I do think, you know, there's reasonable data that we can get in really, if we could improve, especially in the United States, where our really big problem is that we have differing data systems in every hospital and all over the country, and no single health insurer. We have tons of people exposed to bictegravir, and yet we have no PK data, or very little. Maybe we have some recently. So it requires a level of coordination across countries and maybe even continents that's very difficult. Having said that, I think that the newer ARVs get introduced in Botswana and sub-Saharan Africa much quickly, more soon than they were previously. So while we may not be using a ton of darunavir, we are going to get cabotegravir and rilpivirine long-acting very soon. So I think we'll probably still count on many of those places, but we'll just get the ARVs earlier.
So the next question, I think this is for CAHR. This relates to breastfeeding, and a bit of a challenging question, and I'm happy to throw in my 2 cents worth here, but I'd love to hear what you say first. Pardon me. I would like to learn or have information about if in Canada, a young woman who is HIV positive can breastfeed her child. So can you maybe speak a little bit about what the consensus is among the group that you've worked with, if one had to answer that question?
Yeah, so the consensus within our guidelines is to formula feed if a woman living with for a woman living with HIV, and this is because formula feeding is the best way to prevent HIV transmission, because while the risk is low, there is still a risk. And so the consensus is still to recommend formula feeding for women living with HIV.
So if I may just, the question was posted by an anonymous person, so I'm not sure who asked this question, it doesn't matter. I would just also like to say what I think about this. And as someone who runs a program for pregnant individuals living with HIV for about 15 years, we've learned that the answer to this question is not quite so simple. You're absolutely right, what you said. The official guidelines in both Canada and the United States still do say that formula feeding is the preferred choice. And in our program, we always start with that. We want our pregnant individuals to know that that's the recommendation. That doesn't always mean that that's what they will choose. And we don't really have time to go into all of the nuances of this, but many of us in this field know that there's an awful lot that goes into the decision as to whether to breast or formula feed your baby. And I'm sorry, my voice is going crazy here. It is absolutely true that there is a 0% risk of HIV transmission with formula. And unfortunately, we probably can't say that with breastfeeding, although we believe the risk is extremely low. But I do think this is something that's perhaps a hot topic, a kind of new-ish hot topic in the field of pregnancy and HIV. Is something that many of us, both on the obstetrical or pregnancy care provider and pediatric care providers, groups in Canada and the US spend a lot of time talking about with our patients. What I'll tell you is that in a lot of places, including in our program in Toronto, if an individual ultimately makes the decision to breastfeed, we believe it's better to know about that and to help support her through that, versus in the old days when we just said formula feed and we closed our eyes and didn't think about it. So we try very hard to support decisions with informed consent once a decision's been made. So I will leave it at that. We'll go to another question. For Lena, were there any differences observed in pubertal status between boys and girls within the range of the PI inhibitors specifically, and any upcoming data on the integrase inhibitors?
Yeah, so unfortunately, we didn't have enough participants in the different kinds of regimens to say that, because I don't know if you noticed, but with the PIs, especially in the boys being associated with less chance to have reached puberty, we only had 13 boys that had reached puberty at that time. So it's hard to break down by the type of PI. This is an ongoing cohort though, and there's more and more kids are going to be exposed to the integrase inhibitors. We had a very small number of integrase exposures, but these are 9-year-olds. So we're talking about pregnancies that happened 9 years ago. So that number is going to increase now as these kids are aging. And this is something that we're going to follow in this cohort for the long term.
Lena, can I ask you to comment on the association between the viral load and the entry into puberty and what you think about that? I thought that was really interesting.
I thought that was really interesting too, and that it only happened with the boys versus the girls, and it was exactly the opposite of what I thought would have happened. Like my hypothesis would have been the opposite of what that is, and I have no idea. I'm wondering whether it is like a higher degree of inflammation at the time, or to tell you the truth, I don't know what the biological mechanisms would be for that, and why would it be worse for boys than and no effect for girls. But that's something that I'm definitely going to look into it some more.
I would love to ask a pediatric sort of adolescent medicine specialist, maybe even unrelated to HIV, what they think this finding could be. Maybe you and I can explore this a little bit. We can come back with some sort of an answer.
Yeah, I'm all for it. Yeah.
And certainly I'd love to hear what the Peds ID people think about it. So I am going to end now with one more question. Now, where did that question go? There was a question from Marie Soleil, which I no longer see in the chat. And I didn't read it closely enough to be able to replicate it. So I'm really sorry about that. Aha, it's back. Thank you. So Marie Soleil, you were going to have the last question. Were the doses tested at clinically relevant doses and any adverse findings at low or higher doses with the drugs you tested compared to the clinical dose tested?
Sure. So the doses that I tested, typically the 1x Cmax would be your peak plasma concentration found in pregnant women. So that was the dose utilized, and then doses below that as well as above that were examined. In terms of the lower doses, we were seeing adverse effects in all 3 of the second generation integrase inhibitors with BIT-CAB and D2G starting around the 0.1x Cmax, so 10-fold lower than what you would find clinically. We were seeing cell death and that loss of pluripotency. In terms of above that, it was just in the CE1S cells where we went up to 3 times higher than the peak plasma concentration. And just in a dose response manner, it was just more toxic. There weren't any different unexpected results. It just kept getting worse.
Okay, thank you. So I am going to take the liberty of ending us. It's about 5 after 7. I really want to extend a thank you to all of our speakers. All of your talks were really interesting and engaging. And I also want to thank our technical support people that helped us very much with this session. And I believe this is the last session of the conference. I hope that everyone enjoyed virtual CAHR yet again. And I sincerely hope that next year we are all together, finally, able to enjoy an in-person conference somewhere in Canada. Have a wonderful evening and a great weekend, everyone.